My name is Kelly Fleming, and I'm a vascular neurologist. Over the next 20 minutes, I will talk about the epidemiology and natural history of cerebral vascular malformations. While on the surface this seems like a boring topic, as soon as you meet patients, they want to know how common is the disease I have and what's going to happen to me over time. In addition, the natural history is helpful to compare to the risk of treatment when making management decisions. The objectives of this lecture are to understand the prevalence of each type of vascular malformation of the brain, to be familiar with the modes of clinical presentation in individual vascular malformations, and be familiar with the risk of hemorrhage for each vascular malformation and what the risk factors might be. I'm going to be talking about arteriovenous malformations, dural AV fistulas, cavernous malformations, developmental venous anomalies, and capillary telangiectasias. We will start with AVM. AVM are fistulous connection of an artery and vein without an intervening capillary. They are commonly detected on brain imaging, such as MRI, and subsequently conventional angiography. AVM are fairly uncommon, occurring in less than 1% of the population. However, among patients 15 to 45 years of age presenting with hemorrhage, up to 38% may be due to an AVM. Most commonly, AVMs are sporadic, but rare familial forms have been described. In addition, AVM can be seen in certain syndromes like hereditary hemorrhagic telangiectasia or Osler-Rendu-Weber syndrome. Most commonly, AVM are solitary single lesions, but multiple lesions have been described, especially in patients with hereditary hemorrhagic telangiectasia. The supratentorial region is more common than the infratentorial region for patients with AVM. Patients with AVM typically present between the ages of 20 and 40. They may present as an incidental finding. That may occur in up to 40% of people. Patients may present with hemorrhage. Almost half of patients present with hemorrhage, and there are certain risk factors for presentation with hemorrhage. Those include a non-white race, deep location or infratentorial, a single arterial feeder, exclusive deep venous drainage, venous ectasia, and small size. Patients may also present with non-hemorrhagic neurologic deficit, either seizure or focal neurologic deficit. Presumptively, these are due to mass effect, Steele phenomena, or microhemorrhage. About a third will present with seizures, and typically those are AVM in a supratentorial cortical region. It's uncommon to have focal neurologic deficit with no hemorrhage, but this can occur, again, due to Steele phenomena or microhemorrhage. What happens to patients with AVM over time? If you take all comers, the overall risk of rupture is 2 to 4% per year. The biggest predictor of future hemorrhage is prior hemorrhage. Other risk factors include deep location, exclusive deep venous drainage, and large size. You see a Kaplan-Meier curve from data from our institution. On the y-axis, we see patients surviving free of hemorrhage or rupture. On the x-axis, we see time in years. The red line represents those patients that had an unruptured AVM at diagnosis, and the blue line represents those with a prior hemorrhage or hemorrhage at diagnosis. And you see those curves diverge, that those with an unruptured AVM at diagnosis have a 1.77% per year risk of rupture, whereas those with hemorrhage at diagnosis had a risk of 4.82% per year. This is very similar to the Gross et al. Data meta-analysis on AVM risk of future rupture. One thing that is interesting is that if you look at the risk factors for presentation with hemorrhage versus the risk factors for future hemorrhage, they differ slightly. The risk factors for presentation, initial presentation to medical attention with hemorrhage are noted here. And if we compare those with the risk factors of future hemorrhage, there are notable items. Some things are the same, the deep location, the exclusive deep venous drainage, but you'll notice that the size is different in each of the categories. That may be because patients with a small AVM that ruptured at diagnosis is often treated surgically, and patients would be removed from a natural history study. We will now turn to dural AV fistula. Dural AV fistulas are a fistulous connection of a dural artery to a venous sinus. They may be traumatic, often occurring weeks after head trauma, or they may be non-traumatic. As noted in this diagram from a recent article, it is felt that local thrombosis of a venous sinus may result in an angiogenic response and development of a fistula. The incidence and prevalence of dural AV fistula is difficult to define since the diagnosis often requires cerebral angiography, which is an uncommon test. Dural AV fistulas are found in about 1% of angiogram studies in large series and about 15% of all vascular malformations. They are typically solitary, but multiple have been described, and the transverse sigmoid location, as noted here, is the most common. There are several classification systems for dural AV fistula. The most important factor in each of these classification systems is the venous drainage. Type 1 fistulas are generally considered the benign, low-risk fistulas where the venous drainage is into a dural venous sinus and there is no leptomeningeal or cortical venous drainage. The higher the grade, the more leptomeningeal venous drainage that is present. I refer you to the table in the associated chapter for further details of each of the classification systems. Patients with dural AV fistula generally present between the ages of 50 and 60 years of age. The clinical presentation depends on the location of the dural AV fistula and the location of the venous drainage. For example, in a cavernous sinus fistula, one might often see proptosis and chemosis as noted in this figure. Double vision from a cavernous sinus syndrome or retroorbital pain are common. At the transverse sigmoid location, pulsatile tinnitus is the most common, and patients may also have a nondescript headache. The superior sagittal sinus dural AV fistulas may present with more global symptoms. They may have papilledema due to increased venous hypertension, hydrocephalus, dementia and Parkinson's rarely, or seizure. If it is a basilar or petrosal venous dural AV fistula, cranial neuropathies are common. Coma has been described, as has been cervical myelopathy. Let's look further at the demographics and presentation of patients with dural AV fistula by reviewing this table from Gross et al., a multi-center study looking at 276 dural AV fistulas. I first draw your attention to the type 1 dural AV fistulas, those without cortical venous drainage. And important to note is that it's rare to have non-hemorrhagic neurologic deficit or hemorrhage at presentation. Patients may have pulsatile tinnitus, but again, hemorrhage is rare. I'll also draw your attention to this line where the most common location for type 1 are the transverse sigmoid location and the cavernous sinus location. I now direct your attention to type 2. Type 2 in this classification system is a dural AV fistula draining into a venous sinus with leptomeningeal or cortical venous reflux. Several things to note here include that the incidence of non-hemorrhagic neurologic deficit and hemorrhage increase, but that the locations are very similar to those with type 1. I now direct your attention to type 3 and type 4, both high-grade fistulas with direct drainage into leptomeningeal veins, and type 4 having also associated ectasia. Some differences to note here are that there is a male predominance in the type 3 and 4 compared to type 1 and 2. As you see here, as the grading or type increases, the number of patients with associated symptoms increases, including presentation with hemorrhage, and the locations differ slightly, with tentorial petrosal sinus and ethmoidal sinus more common as you get higher in the types or grades. When you take all comers, the overall risk of hemorrhage from a dural AV fistula is 1.5 to 2% per year. As with other vascular malformations, prior hemorrhage predicts future hemorrhage. In addition, a higher grade or type lesion with cortical venous drainage increases the risk. So what happens to patients with dural AV fistula over time? This data comes from the multi-center study by Gross et al. In 2018. For those with a type 1 fistula, they were followed for an average of 1.4 years, and no patient developed a non-hemorrhagic focal deficit, and no patient developed hemorrhage. In the higher grade type of dural AV fistula that presented to medical attention without any symptoms, the risk of non-hemorrhagic focal deficit and hemorrhage were approximately 2.3% and 2.9% respectively. The relative follow-up was short, about 1.6 lesion years. In a high-grade fistula that presented with non-hemorrhagic focal deficit, the risk was 23.1% of developing a non-hemorrhagic focal deficit over time and a 3.3% per year risk of hemorrhage. In patients presenting with a high-grade fistula with hemorrhage at presentation, none developed a non-hemorrhagic focal deficit, and nearly 46.2% developed recurrent hemorrhage. Thus, the higher the grade and the more symptoms they have at onset, the more likely that hemorrhage will occur. We will now turn to cavernous malformations. Cavernous malformations are an angiographic occult vascular malformation composed of multiple endothelial-lined caverns. Radiographically, you see a central T2 signal that looks reticulated with a surrounding hypointensity suggestive of hemosiderin. Macroscopically, it looks like a mulberry or raspberry, and each of these endothelial-lined caverns has either thrombus or blood within it, and that is what's reflected on the MRI imaging. At the microscopic level, what is dysfunctional in cavernous malformations is the endothelial tight junctions and the leakiness of the endothelium. This leakiness results in clinical symptomatology. Cavernous malformations are fairly rare entities. They occur in 1 in 200 to 1 in 500 people. There are 3 types. The sporadic form is characterized by a single lesion, often associated with a developmental venous anomaly. The associated developmental venous anomaly is thought to be involved in the pathogenesis of the cavernous malformation, in addition to possibly the natural history. The familial form is characterized by multiple cavernous malformations, and you can see here that sometimes patients have innumerable cavernous malformations on the susceptibility weighted imaging. There are 3 known genes, CCM1, 2, and 3, and all are autosomal dominant. Patients may also develop cavernous malformations after a history of radiation to either the brain or spine. The radiation-induced cavernous malformations typically occur 2 to 20 years post-radiation and are often in the port of the radiation. Patients with cavernous malformations may come to clinical attention for a number of reasons. In some cases, up to 40% may be an incidental finding. The MRI scan or CAT scan was done for reasons other than the cavernous malformation. In up to 30% of patients, they present for the first time to medical attention because of hemorrhage. Most commonly, these patients present between their 20s and 40s, and they often have a brainstem location lesion. Non-hemorrhagic deficits from cavernous malformation are felt to be due to either microhemorrhages, local compression, or irritation of the brain. Seizures occur in about a third of patients, more commonly if they have a supratentorial, cortically based lesion. Focal neurologic deficit without hemorrhage is very uncommon, but can be seen in patients probably due to microhemorrhage. Seizures are the most common symptom in patients with supratentorial, cortically based lesions. Hemorrhage, however, is the most common presentation for brainstem cavernous malformations. Patients want to know what will happen to me with time. What is the natural history of cavernous malformation? And there have been a number of prospective studies looking at this very question. Some are single center, some are population based, and some are based on location only. And when you put all patients together, the overall risk of hemorrhage is about 1 to 4% per year. However, the risk varies depending on specific features. Here is a table of select prospective cavernous malformation natural history studies. What you see is that most studies show that prior hemorrhage predicts future hemorrhage. This is a very consistent finding in many of the vascular malformations. Some studies suggest that brainstem location is significant, and some, but not all, suggest female sex or multiplicity might be a factor. There have been 3 meta-analyses of data, including this one from Horn, which was an individual patient data meta-analysis. It included 620 patients from 7 cohorts, and prior hemorrhage and brainstem location were most significant in predicting future hemorrhage. Another study also found the same thing when they assessed 25 cohorts using both retrospective and prospective natural history studies. Gross and colleagues looked at 12 cohorts of 1,610 patients, and again, prior hemorrhage predicted future hemorrhage. This is data from the Horn study. The y-axis shows the proportion of people progressing to a hemorrhage. The x-axis shows time in years. The red line represents patients with brainstem location cavernous malformations that initially presented with hemorrhage. You can see they have the highest risk of recurrent hemorrhage of 30.8% over 5 years, or roughly 6% per year. The blue line represents those patients with a non-brainstem location cavernous malformation that presented with hemorrhage. Their risk over 5 years is approximately 18.4%. The green line are patients with brainstem location that did not present initially because of hemorrhage, and the gray line represents those non-brainstem location that did not present with hemorrhage. You can see in each of those two groups, the hemorrhage risk is quite a bit lower than those who presented with hemorrhage. The other thing that you see on this graph is that the lines seem to plateau around 2.5 to 3 years. This clustering effect of a second hemorrhage is common, with the time to next hemorrhage after first hemorrhage being about 8 to 10 months. We're now going to turn to developmental venous anomalies. Developmental venous anomalies are composed of radially arranged medullary veins that converge into a single venous channel. Here you see a 7 Tesla MRI T1 with GAD and a susceptibility weighted image. You see the typical witch's broom type shape. Developmental venous anomalies are the most commonly detected cerebral vascular malformation. They occur in 0.5 to 11% of people. They are typically solitary, but multiple have been described. Here you see a developmental venous anomaly with the radially arranged veins. They are typically more common in the supratentorial region than infratentorial, and they may be associated with cavernous malformations. Here you see a developmental venous anomaly noted by the blue arrow. You see a large cavernous malformation in the pons, and on the susceptibility weighted image you see another small cavernous malformation on the opposite side of the developmental venous anomaly. While typically the sporadic form cavernous malformation is a single lesion, if they cluster around a developmental venous anomaly, it is still considered a sporadic cavernous malformation. Developmental venous anomalies are most commonly an incidental finding. In the Scottish intracranial vascular malformation study, up to 97% were asymptomatic. Hemorrhage is rare. If you do see it, you might want to look for an associated cavernous malformation, which is more likely to bleed than the developmental venous anomaly. Non-hemorrhagic symptoms including seizure and focal neurologic deficit have been described, but are also rare. These may be caused by compression, thrombosis of the developmental venous anomaly, or due to inflow or outflow abnormalities. So what happens to patients with developmental venous anomalies over time? This chart is from an article in Stroke from 2009. Authors collected natural history studies of patients with developmental venous anomalies if the study included more than 20 participants. I'll draw to your attention that most of the studies included small numbers and short duration of follow-up. What were the results? The hemorrhage rate was anywhere from 0 to 1.28% per year. I highlighted the only population-based study which reported a 0% risk of hemorrhage. I will also highlight this study which reported a 0.34% per year risk of hemorrhage based on one hemorrhage in the prospective follow-up time. There's a small asterisk by the 1, and the asterisk reads, "This may be due to an undocumented cavernous malformation." Other studies have similarly reported that if you see a developmental venous anomaly with associated hemorrhage, you should first look for a potentially associated cavernous malformation, which is more likely to bleed. Overall, I conclude that the risk of hemorrhage from a developmental venous anomaly is low from these studies. We will now turn to the last category of capillary telangiectasia. Telangiectasias are dilated capillaries with normal intervening neural tissues. Here you see a patient who has 2 capillary telangiectasias with slight blushing on T1 with gadolinium. Capillary telangiectasias are fairly rare. They are typically a solitary lesion, often in the pons in up to 2/3 of patients. They are characterized by this blush on T1 with GAD and hypointensity on susceptibility weighted imaging or gradient recall echo. They are commonly very small, less than 4 millimeters, but those greater than 1 centimeter have been described. Capillary telangiectasias are rare to cause symptoms. In one large meta-analysis, less than 6% had symptoms relevant to the localization of the capillary telangiectasia. There are no large natural history studies, and hemorrhage is very rare. In summary, most vascular malformations of the brain are incidental findings. Patients with vascular malformations may present with or without hemorrhage. Non-hemorrhagic lesions can cause symptoms due to mechanical compression, local irritation of the brain, steal phenomena, and shunting characteristics that may result in venous hypertension. The overall risk of hemorrhage for AVM, dural AV fistula, and cavernous malformation is approximately 1 to 4% per year. The individual risk varies depending on other characteristics. Developmental venous anomalies and capillary telangiectasias rarely bleed. Prior hemorrhage generally predicts future hemorrhage in all of the vascular malformations, and the rate of rehemorrhage is higher after the first bleed. Risk factors for hemorrhage vary by vascular malformation. The natural history is useful in that it must be weighed against the risk of treatment so as to make appropriate management decisions. I have included this slide, which summarizes the prior slides and the text. And thank you for your attention.